Support Microbe TV. It's time for our annual fundraising drive. We depend on your support to produce high-quality science videos and podcasts, and now is the time to help us. If our programs have appealed to your science interests, or if they have helped you in some way, please record a brief audio or video with your phone and tell us about it. Let us know how we empower your inner scientist. We'll use it for our fundraising efforts. Send it to incubator@microbe.tv. And for more information on how you can give us your support, go to microbe.tv/contribute. This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV. This Week in Virology, episode 1170, recorded on November 27th, 2024. I'm Vincent Rackaniello, and you're listening to the podcast all about viruses. Joining me today from New York, Daniel Griffin.
Hello, everyone.
We're recording on the eve of Thanksgiving, but when this drops, the holiday will be over.
You know, it'll be the, so we'll have here in the U.S. for our international listeners, Thursday is Thanksgiving Day, right? This is I think it was the first time that, natives of our great country gave free food to illegal immigrants.
And what did they get in return? They got kicked out. Oh my gosh.
So, and then Friday is Black Friday, when we basically buy things. We're people don't know, Americans, we're at heart capitalists, if nothing else. That is one thing that we were always true to.
Oh, Daniel, but just wait. Now we're going to have tariffs that are going to raise prices. No more Black Fridays.
Yeah, I don't know what's going to happen there. So that's
now, Daniel, your tie is very dark. I have no idea what's on it.
So it is, I thought it was very Thanksgiving-esque. So it's got sort of this brown colors and these red flagellated beaver fever organisms. So it's Giardia. So I thought that was appropriate. But yes, so when this will drop, it'll be Saturday. So this is often, Vincent, I don't know if you know, this is when our TWiV aficionados rope in, the uncle from Boston, everyone else. You got to listen to this great science-based podcast. And we'll.
Well, you should do that. And also at the Thanksgiving table, don't forget to mention to go to parasiteswithoutborders.com and donate to Microbe TV, and your donations will be matched.
Exactly. All right, well, let's jump in. I'm going to start with a Dostoevsky quotation. Nothing in this world is harder than speaking the truth. Nothing easier than flattery. And maybe that's very appropriate, and that's all I will say on that topic. Okay. Moving into influenza, and what was it? Someone recently said the holiday season is the season of respiratory viruses. And that's really the case, right? So we usually, think of us last year at about this time, we were just starting to see some activity. District Columbia, Georgia, Louisiana, starting to get into the low, moderate flu activity. In general, we're still minimal, but this is when everyone gets together, and then usually December, January, things rise. I'm going to leave in a couple links. There's an epidemic trend map, and you can see all the areas where flu activity is growing, right? So the entire West, going to say Washington all the way down to Texas. Just think of that swath here in the Northeast, New York, Connecticut, Massachusetts. So we will see in coming weeks. And RSV, respiratory syncytial viruses. Yes, this is TWiV listeners, educate family and friends about RSV, not the RVP virus, but the respiratory syncytial virus, right? We now have ways of protecting the youngest among us and the oldest among us. So, and bird flu. Lots of questions here. So, Vincent, are you up for a short discussion about bird flu?
Of course.
All right. So I'm going to leave in a link to the News Explainer. And this is in Nature. So it's a Nature News Explainer article. Why a teenager's bird flu infection is ringing alarm bells for scientists. And then I'm also going to leave in a link to the MedCram video, H5N1 mutation detected in Canadian case favor human transmission. So we previously discussed the child up in Vancouver, Canada, a teenager who ended up in critical condition after being infected with an avian influenza virus. And what has gotten people talking, what Vince and I are going to chat a little bit about, is the viral genome sequences released last week. Suggested that the teenager is infected with an H5N1. So this is that avian influenza virus, the bird flu. And as they say, bearing mutations that might improve its ability to infect the human airway. So I watched the MedCram. It's actually quite good. It's very sophisticated. I was impressed. Vincent, what's going on?
Well, if this were going to be a pandemic, it would already be here. So you remember 2009 H1N1? They saw a few cases, and then all of a sudden, boom, they're all over the place. It's not like, oh, we see this case, and we wait a couple of weeks, and then, no, it would be starting already. Now, I'm not saying this is not why we shouldn't not worry about it. We should be reasonably prepared. But what's going on? So the Canadian case, there's no cow involved because there are no cows infected in Canada with H5N1. So it's an avian source. It has changes in the genome that are needed for transmission. But as we learned in 2015 from the Fouchier and Kawaoka experiments on transmission in ferrets, you need more than just a few changes in the HA and the polymerase. You need other changes as well. And these don't have them yet. So they're needed. I wouldn't say favored transmission. They're needed for transmission, but they're not sufficient. And who knows? It's not ready to prime time, this virus in Canada.
Yeah.
That's it.
Yeah, I have to say, I am not as, as they say, alarmed. I don't hear the alarm bells ringing. And, it's interesting that ferret experiment gave us really, I think, helpful information for us to put this into context. I think that was like what people got a little upset about, the concept of that as gain of function, right? Because it was like gaining function to transmit in the ferrets or something. Yeah, I think, I'll leave in these links. People can look into this. The sky is not falling. The end is not in sight. I will also mention the CDC confirms H5N1 bird flu infection in a child in California. This is maybe a little bit different. So the CDC confirmed that this child in California is the first child in the United States ever to be infected with an H5N1 is my understanding. Now, this is actually along the lines of some of the other cases we've been seeing here in the States where, I'm going to say we see two types. And Vincent, you tell me your thoughts on this. So we tend to see this, I'm going to call it the cow-adapted H5N1, right?
Mm-hmm.
And they tend to be mild because of receptors, sialic acid receptors, often like eye involvement, mild symptoms. When it jumps directly from the bird to human, that is often when we see the sicker individuals, like the described case up in Canada. And this case here, the child, mild symptoms, got some flu antivirals, actually is reportedly doing quite well.
I want to make a comment, Daniel, and you can not say a word. I will understand. Okay. If we have a pandemic of H5N1 in the next year, we can't have any infectious disease research. All of the science establishments are going to be broken by the next administration. So, folks, worry about it in that sense. I'm not so worried about the virus, but I'm worried about our response should it become a pandemic.
All right. Well, along those lines, we also hear, are you ready for this, Vincent? Bird flu detected in raw milk sold in California. And I'll leave a link into that. So.
Well, listen, bird flu is a disease. So they did not detect the disease in the milk. They detected avian H5N1 influenza virus. Okay.
And probably just the genetic material. Like we don't even
Yeah.
know, like probably not like, doing plaque assays or anything. So.
Nope.
So, all right, just to put that in context for all the raw milk drinkers among our listenership, maybe just among our listenership this one episode. COVID update, still a couple areas, Minnesota and Mississippi. I think I'm getting that right, in the 2 to 4%. The rest of the country, we're in the less than 2% of deaths are due to COVID. Kind of crazy, right? That I'm reassured, less than 2%, less than 1 in 50 people who died this last week died from COVID. I mean, it's here to stay. But the wastewater is reassuring. It's, last year about this time, we were already seeing a rise. But if you look at the wastewater across the country, everywhere it's minimal. So that's I think encouraging. This doesn't rely on us making the diagnosis. It doesn't rely on people getting sick. All this is basically people are using the toilets, and so this is encouraging.
We may enter December without a rise, Daniel.
We're almost there. Yeah, actually, when this drops, it'll be December. So yeah, gonna see what happens. We should have like a bet for what's going on January 1st, right? So I'm hoping that Vincent is right, and we just had so much immunity from this fall surge that we're going to get a little bit of a break. But we are starting to see the epidemic trend. We're starting to see some areas where actually things are growing in the wrong direction. So it's really minimal level, a little bit of a trend in the New York area, a little bit of a trend in the Midwest, a little bit of a trend out west and Texas area. So. We'll leave in some more links for people to look into that. But all right, the article, Association Between Use of a Voluntary Isolation Center and Reduced Household SARS-CoV-2 Transmission, a matched cohort study from Toronto, Canada, published in CID. So I'm going to start by reading the background. So throughout the COVID-19 pandemic, many jurisdictions, this is in Canada, established isolation centers to help reduce household transmission. However, few real-world studies support their effectiveness. So here, what they did is they compared the risk of transmission among households where first case used the Toronto Voluntary Isolation Center, opposed to some of those mandatory isolation centers in other parts of the world. And they compared folks that took advantage of this voluntary isolation compared to households that just kind of did the routine self-isolation. And this is data from prior to vaccine availability, right? So we got to put that in context. So the first thing I did was to stop to see, where were the authors from? Because I think this matters, right? So as I mentioned, this is Toronto, Canada. We really did not do this isolation center thing here in the US. And as I mentioned, there's some areas in the world where it was mandatory, right? Like if you got a positive diagnosis, you were in a mandatory isolation center. So the median duration from the first case symptoms, this matters, to checking into the isolation center was 3 days, right? So there was a certain amount of like height of transmission prior to check-in. The median check-out date was 11 days. The attack rate among households was 5.2% in the folks that use these isolation centers, compared to 8.4% where people just did it on their own. I think people can guess that quicker you went and isolated, the more significant reduction in transmission. Also, larger, more crowded households, getting out of that context made a big difference. So, in general, we saw about a 50% reduction in the household SARS-CoV-2 attack rate prior to the availability of vaccines if you actually left the house and took advantage of one of these.
So what is this isolation center? They take a family from a house and put it in another house? Is that how it works?
No, it's really like individuals, right? So these are individuals, and they basically, hey, I got COVID. And then they go and you get like, you get your room. I mean, I can see some of the places like in China, for instance, I saw some of the photos. It was like a big sort of hall, like everyone in there was COVID. It was sort of the idea that there was a particular variant. Everyone else had the same variant, fingers crossed. In other areas, I have to say, like in Germany, where people were ending up, getting a particular infection, they were trying to cohort them by variants, right? You didn't end up with one variant. Now you've got a second variant, right? Because we saw that you can get, and then you might even get mix and match.
So did you have to stay in your room? Is that the idea?
That's the idea. Yeah.
And what do you do for food? People bring you food?
Yeah. Yeah.
Okay. So this is not sustainable on a large scale. Okay. And the U.S. would never do it, right? In the U.S., the family is the nucleus, right? So you take a member out of the family and put them away for whatever, 10 days, it's not going to work.
Yeah.
So
what we did here, right, is you like, hey, you stay in your own room, wear a mask when you come out. Yeah.
I don't even know why we bothered to look at this kind of thing. I mean, maybe there are some countries where they enforce it and they think it's useful, but
well, I sort of applaud them. Like people went ahead and they did stuff that they thought made sense. And so it's important for the next pandemic to ask, like, did this work? And it actually say 50% reduction. That sounds great on the surface, but then you're like, okay, so wait a second. You went from 8.4 to 5.2. So that's about a 3% reduction. And so an absolute 3%. So, how many people do you need to isolate to protect one person from getting it? And that starts adding up. It's a lot of money. It's a big investment. So it's sort of important
Also, the psychological impact of disrupting a family, putting someone away for 2 weeks or whatever, that's not good. I mean, they can't work. So I think there are all kinds of problems. We should have learned that the lockdowns and isolations were really disruptive measures that messed up far more than infectious diseases, right? So I would not do this.
Yeah. No, I mean, I think, and this is probably a good time to mention this and probably the right audience to mention this. We got a lot wrong. There were a lot of missteps.
Yes, for sure.
And we got it wrong. It wasn't like there wasn't some group of people that got it all wrong. And then, there was the bunch of us now who are angry because we knew. A lot of this was people had good intentions, but it's important to do the science like this so that, we could say, that was a bad idea. That did not work. All right. So vaccinations. Ooh, this is a hot topic, I guess. I'm well aware that not too many people have gotten or are planning on getting the updated COVID shots. So we're going to discuss the percentages on that a bit later. But first, we have this article, Risks of SARS-CoV-2 JN.1 infection and COVID-19 associated emergency department visits hospitalization following updated boosters and prior infection, a population-based cohort study published in CID. So, it always takes time to get the data. So here we're getting the data from a booster during, this past period, right? So let's just put this in context. So fall 2021 is when Omicron was declared a new variant of concern, starts to spread. And so here we're looking at 26 November 2023 to 13 January 2024, right? So this is last year, just to put this in context. And they conducted a retrospective population-based cohort study looking at Singaporeans aged 18 and over. All right, so we're going to look at the impact of boosters, prior infection, basically what happened last year. And then hopefully we're always going to be like 1 year behind. So this is another one of those real world studies where we see what is happening at a population level. So here's a total of, you ready for this? Over 3 million. So 3,086,562 boosted adult Singaporeans looked in this study. And then they throw us even this big number, 146 million person days of observation. During this period of time, 28,160 infections were recorded, 2,926 hospitalizations, 3,747 ED visits. And so they compared individuals that had been last boosted greater than a year ago to those that had just gotten the XBB booster 8 to 120 days earlier. They found that getting an updated booster 8 to 120 days earlier was associated with a lower risk of getting the JN1 infection, about 41% reduction. So hazard ratio 0.59. What about your chance of ending up in the ED, right? So we saw almost 4,000 ED visits. Folks that got boosted had about a 50% reduction in those ED visits, and hospitalization about the same, so a 42% reduction, so a hazard ratio of 0.58. Get a few other little bits of data. What if it's a little bit longer? Let's say a little bit past, so 121 to 365 days earlier. You really were losing almost all the protection. So hazard ratio 0.92 for infection, 0.80 for reduction in ED visits. But what about what I think I could say we, Vincent and I care about, what about severe disease, right? So you get an infection, maybe you go to the ED, but what about getting sick enough to end up in the hospital? And so here you're actually seeing, even if you look past the 120 days, folks that had gotten an updated shot 120 to 365, up to a year before, there was a 43% reduction.
So this is a year ago till January, basically.
So basically they looked at last fall, winter, and they said, let's look at people that got a booster or didn't, and yeah.
So what's circulating at that time? Which variant?
So that was so they say here it was the JN1 variant.
So the booster is XBB, which is different, right?
Yeah.
Okay.
Interesting, right?
So basically, you don't need a JN1 update to get protection.
Well, particularly when you looked about severe disease, right? That looked like there was, a variant, so interesting.
I mean, there's the risk of infection. I don't know how, I don't really care about that, but ED visits and hospitalization, and this is good that the previous booster will do it against the new variant, right?
Yeah. And it looks like, so we'll talk about, I think this is so repeatedly we've discussed that immunity has really changed the outcomes with COVID-19. And for most people at this point, this is a combination of vaccination and prior infection, so hybrid immunity for most folks. But unfortunately, here in the U.S., we now have over 1.2 million individuals who died with their deaths attributable to COVID-19 on their death certificate. We're still seeing thousands of people end up in the hospital each week due to COVID-19, thousands of deaths. And I don't want to leave this out. We also now have over 1 million individuals suffering from long COVID here in the United States. So with that said, and the fact that getting vaccinated and getting boosted reduces an individual's risk of infection, the need for medical attention, a trip to the ER, hospitalization, death, and we're going to talk a lot more about this post-acute sequelae of COVID, long COVID. How are we doing with people getting those boosters here in the U.S., right? I mean, it must be lines like, people wondering if a new Star Wars episode came out, right? Everyone wanting to get updated vaccines. Yeah, apparently not. So here we have the MMWR coverage with influenza, respiratory syncytial virus, and COVID-19 vaccines among nursing home residents, National Healthcare Safety Network, United States, November 2024. So of course, these numbers are going to be super high because these are the most at-risk individuals. So let's look at the numbers. For flu, only 58%. COVID-19, 30%. RSV, 18%.
Daniel, obviously the residents of these nursing homes have a say in whether they get vaccinated or not, right?
if they're offered, right? I mean, I think that's the thing is the nursing home has to make it available. They have to offer it. They have to,
Because this is the key population for these vaccines, right? Yet 30%, 18% is crazy. So you think they're just not offering it?
Yeah, there. I mean, a lot of facilities are not making
Wow,
this happen.
that's crazy. And I bet this goes down next year even more.
I think you're right. And I'm sort of a little bit baffled, right? So we've been told, recently, don't say vaccines are safe, effective. You're supposed to be saying the risk benefit profile clearly favors vaccination. I'm not so sure about this, right? And so I put in this little section. I was sort of trying to figure out the disconnect here. And you and I are old enough to remember the 1980s. Remember when seatbelt laws were being introduced?
Oh, yeah.
I distinctly remember a Thanksgiving, where this was the topic of the heated topic of conversation. And so when these were being introduced, right, in the 1980s, what percent of Americans at that time opposed enforcement of seatbelt laws? 65%. The majority of Americans, like this is one of those like minority of Americans are forcing this on us. And I remember and I went through and looked these up. So what are the arguments? What do people say? Number one, it's uncomfortable. It's cumbersome. It's going to wrinkle my shirt. The next, and this was the big one. This was really passionate. It's going to make it difficult to escape a damaged car. It's safer to be thrown from a car at 65, I think it was 55 back then, 55 miles per hour. If I get into a car accident, I want to be free of the seatbelt so I can be thrown through that windshield and end up on the side of the road, safe and clear from the accident. And then the anecdotes, right? The anecdotes about seatbelt injuries, right? I knew this guy and he was belted in and he was in a crash and the car was completely mangled and he had bruising across his sternum.
Oh, but he was alive, right?
Yeah, but he had bruising across the sternum.
Oh, terrible.
And,
Daniel,
and then the last is like, how am I supposed to maneuver the car, right? That was like the Volvo versus Subaru, right? Volvo was like, we're going to keep you safe. And then, the Subaru drivers were going to like maneuver and not end up in an accident, so.
Daniel, aren't airbags now mandated as well in cars?
These coastal elite liberals, next thing you know.
But people don't object to airbags. They don't have any choice. They can't not turn it on, right? Basically.
I don't think there's quite as much of a anti-airbag. But yeah, no, I've been like people worried about, I'm not tall enough. The airbags are one size fits all.
Yeah.
I need to like go to the dealer and have them, disable my airbag. So,
So it's interesting. This law would never pass today.
Definitely wouldn't pass in the next couple of years. Yeah.
And I wouldn't be surprised if it were repealed by some wackos.
I wonder if this isn't, enough in the rear view mirror that, people aren't going to try to like overturn and, sort of the libertarian, like, wear your seatbelt if you want. A human being should have the freedom, to drive around, unrestrained. And, and I remember, right? I remember when we were kids, piled in the back of the station wagon, unrestrained. The good old days when America was great, when the way that we resolved sibling conflicts was when one parent would yell at the top of their lungs, "Don't make me stop this car." All right, so let's move on to the early viral phase. So now, unfortunately, someone has been breathing and someone else has been breathing in, and we end up getting COVID. We still have our NIH treatment guidelines. We have our ID Society of America guidelines. I just renewed my membership, so hopefully that'll keep moving forward. Number one, Paxlovid that we've been talking about, number one recommended, about a 90% reduction in progression. Also, as we've been talking about, if you use the umbrella of post-acute sequelae of COVID, cardiovascular issues, etc., significant reduction. Number two, remdesivir. And for those that say like, oh, this is not a big deal, remember, thousands of people still getting hospitalized here in the US alone. And number three, what about molnupiravir? What about Thor's hammer? And I will admit, I have never been too enthusiastic about molnupiravir once we got the full data. But we do have the article, Real Clinical Effectiveness of Molnupiravir Against 30-Day Mortality Among 74,541 SARS-CoV-2 positive patients, a nationwide cohort study from the Czech Republic, published in Open Forum Infectious Disease. So I wanted to start off by first, what is a real-world effectiveness study? What is that? Is this just a rebranding of the terminology retrospective cohort study? So a real-world effectiveness study refers to an observational study that examines treatment effectiveness in a typical clinical setting, often using readily available data, while a retrospective cohort study is a specific type of the observational study where the researchers look back at data from a group of individuals where the exposure and outcome have already occurred, meaning they are analyzing data collected in the past. Essentially, a retrospective cohort study is a method that can be used to conduct a real-world effectiveness study, but not all real-world studies are necessarily retrospective cohort studies. So I'm going to say, yes, pretty much real-world effectiveness study is a bit of a rebranding of retrospective cohort study in most cases. So the authors even challenge the respect we are giving to randomized controlled trials as they write in the background section. You ready for this, Vincent? Although RCTs, randomized controlled trials, are the gold standard for drug efficacy assessment, their findings may not apply to real-world populations because they usually focus on selected patients who differ from the real population in routine clinical practice.
But Daniel, isn't the trial population selected to try and be as diverse as possible?
Yeah, I just want to make sure that, So here they report the results of a population-wide retrospective cohort study in the Czech Republic. They analyzed 74,541 patients with an officially registered diagnosis of SARS-CoV-2 infection, January 1 through 31 December 2022, aged 18 and older. Primary outcome, 30-day all-cause mortality. The use of molnupiravir in adult SARS-CoV-2 positive patients was associated with a lower risk of both 30-day all-cause mortality, so about a 42% reduction, and 30-day COVID-19 related mortality, about a 50% reduction. And they saw this regardless of sex, severity, hospitalization status, vaccination.
So if you can't get Paxlovid, this is not a bad alternative.
Yeah, if you can't get Paxlovid, if you can't access remdesivir, there might be some mortality reduction. But the other, and this is the next article, time to sustained recovery among outpatients with COVID-19 receiving Montelukast versus placebo. This is this issue that maybe it makes you feel better, right? And that's a thing that people have asked as well. Are we doing molnupiravir to make people feel better quicker? Are we doing it to keep people out of the hospital? None of those endpoints have been that impressive, but at the end of the day, maybe it's reducing your chance of dying.
That's probably the best outcome, isn't it?
It's a great outcome, but you want all the others too. You don't want to end up in the hospital. You don't want to end up with long COVID. You don't want to, some fates are worse than death, right? And for a lot of people, I have to say, with long COVID, they are miserable, right? And we've had some individuals actually take their own lives because they are.
Okay. Point taken.
Okay, so convalescent plasma in some situations, and moving on to early inflammatory phase. So as I mentioned, we're still in the U.S. seeing it's about 5,000 or 6,000 people being hospitalized per week with COVID. Usually because they're in that early inflammatory phase. Sometimes it is in that first week as well. But if they're in their early inflammatory phase, often during the second week, but COVID doesn't always respect that calendar, is when people might become hypoxic and steroids might be appropriate. We have anticoagulation guidelines, pulmonary support, And still, in some cases, there might be a window for benefit for remdesivir. So, right, remdesivir, first week, 3 days. Remdesivir in people requiring oxygen support. We have the article Remdesivir for treatment of COVID-19 requiring oxygen support, a cross-study comparison from 2 large open-label studies published in CID. And I have to say, we keep learning about remdesivir. For instance, we learned about it being safe to use in folks with renal failure. So I'll also leave a link into efficacy and safety of remdesivir in people with impaired kidney function, hospitalized for COVID-19 pneumonia, a randomized clinical trial. But here we actually are going to be looking at folks who are hospitalized, right? And in general, we're using 5 days. Why 5 days? Why not 10? That's because we have that New England Journal of Medicine article, remdesivir for 5 or 10 days in patients with severe COVID-19, where we actually saw that people did better. It was actually a trend towards 5 days as the optimum duration, a trend away from doing too much. And here we actually find that whether they're just using nasal cannula, whether they're on high flow or non-invasive positive pressure support, whether they're ventilated, even whether or not they're on ECMO, we're actually seeing about a 50% reduction in mortality in all these contexts. Okay. And in some contexts, immune modulations with tocilizumab. And I'm going to wrap us up with two things. One is the late phase past long COVID section. And I will, to be slightly political, Vincent, I was a little concerned when I heard a nominee to one of our federal agencies say that long COVID was real, but overplayed. For the millions still suffering from long COVID, let me say long COVID is real, and if anything, has been underplayed. So we have the article, Neurological Manifestations of Long COVID Disproportionately Affect Young and Middle-Aged Adults. Here, these investigators sought to investigate neurological manifestations of post-acute sequelae of SARS-CoV-2 infection, so neuropasc, in post-hospitalized. So we have a post-hospital neuropasc, which is PNP, and a non-hospitalized neuropasc patients. What did they basically find? There was a significant age-related difference in really a number of things. So they divide the patients into those who are younger, middle-aged, older, and they found that fatigue, sleep disturbances, and higher impairment in quality of life among the younger patients. There were significant age-related differences in objective executive functioning and working memory, with the worst performance coming from the younger group. So I think I would say that in general, the older you are, the higher your risk is of long COVID, but some of the most severe cases we're actually seeing in these young individuals, 18 to 44, and middle age, 45 to 64.
By the way, I heard that physics girl is getting better.
She actually is, and I'm gonna hopefully jump on a call with Kyle and Diana Coward when I get back from Africa. I was delighted. I don't know if people are aware, but Physics Girl really has been suffering horribly from long COVID, debilitated, and she's now talking up to an hour a day. She recently recorded a video, so tremendous to see that there's some improvement there. And I think there's been a bit of a fundraiser, and I talked to Kyle, and I'll talk to Diana, as Kyle is her husband, about possibly what can we do to help with awareness and help support those. All right, so a recap for any new listeners today, and also our longtime listeners. So it's been about 5 years since this virus crossed over from animals at the wet market in China and got into the human population before spreading throughout the world. And I'll leave a link into the TWiV special, How the Pandemic Began. I give people permission to fight about this while gathered together for the holidays, because the lab leak conspiracy theory is not innocuous. And I'll read from a linked article here. The unsubstantiated claims of the lab leak theory have provoked harassment, intimidation, threats, and violence towards scientists, which are often vile in the online space. An article in Science reported that of 510 researchers who had published on SARS-CoV-2 or COVID-19, 38% acknowledged harassment ranging from personal insults to threats of violence, docking, and personal contact. A second survey, which included 1,281 scientists in a wide range of fields, found that 51% experienced at least one form of harassment, sometimes repeatedly for years. Most worrisome for future preparedness, the next generation of scientists has well-founded fears about entering fields related to emergence viruses and pandemic science. As far as transmission, it's basically the same virus and just as easily spreads from person to person. But this virus is now encountering a wall of immunity that we have built with prior infection and vaccinations. We covered this by discussing those articles looking at secondary attack rates or the chance of people getting infected being around someone sick with COVID-19, and I'll leave a link into a few articles. But studies that show no intrinsic difference in the virus. Really, the difference that we are seeing is because of this wall of immunity. And as we've discussed again today, getting into a cadence of yearly boosters reduces an individual's chance of getting COVID. Then based who you are, your chance of feeling rotten, your chance of needing medical attention, going to the ER, getting hospitalized, dying, or suffering from long COVID. And if you don't like the mRNA stuff, we have the more traditional vaccine choice, Novavax. And if you do get sick, we have highly effective medications. So call your doctor to see if that might be right for you. I feel like it's a commercial. And if you do end up with long COVID, we are learning more. We do have evidence-based treatment and a growing number of long COVID treatment centers, such as the one we have right here. I'm going to say right here at Columbia. And I'll leave in a link to that center. You can also call 877-426-5637. And I will wrap it up as I have been for quite a while. No one is safe until everyone is safe. I want people to pause the recording, go to Parasites Without Borders, click on donate. Every small amount help. We're going to continue to support Microbe TV. We're in the midst of our fundraiser, hoping to get up to a maximum donation of $20,000 for Microbe.tv.
It's time for your questions for Daniel. You can send them to daniel@microbe.tv. Chris writes, I would appreciate your opinion on the importance of fall boosters for kids 4 to 9 years old. My daughter-in-law says their pediatrician isn't recommending vaccines and is saying that they've all had COVID. Their risks of the disease are low as healthy kids. I do not agree, but don't know how to present it to my daughter-in-law. They have had only the initial 3 shots and do not have any health conditions that raise the risk of COVID illness. Thank you.
Yeah. So what are we trying to prevent with the vaccines? And we've been through this. And with kids, we'll put it in context. So here in the United States, over 1,000 children died of COVID. And I want to point out the majority of those children, not just a little over 50%, but 75, 80% of those deaths occurred after Omicron, right? So these are deaths due to Omicron, which is the current virus that they'll keep telling you is not a big deal. But it is a big deal. So we have, death. We also have long COVID in kids, right? And one of these federal appointees, who claims that we're overplaying long COVID, was saying, oh, we only see it in 1 or 2% of people after infection. 1 to 2%. Every time you get COVID, you have about a 1 in 50 chance that you're not going to be better in 2 to 3 weeks, that you're going to be sick for months. Vaccinations, clearly, and we're going to present about 50 studies next week about vaccinations reduce the risk of long COVID, old people, middle-aged people, young people, young people. So long COVID protection, protection against death, protection against getting sick. Also, we know that the duration of illness is significantly reduced. So that vaccination for your child can get them back to life a bit sooner, get them back to feeling better a bit sooner. But yeah, the big specter for the kids is long COVID.
Mary writes, thank you for your ongoing commitment to providing science-based information about COVID and other infectious diseases. The first thing I do on Saturday morning is listen to you and Vincent in Clinical Update, and it starts my day on a positive note. In the November 22nd episode, you mentioned that you care for some people who have a long COVID-like syndrome after vaccination. A close friend had her life turned upside down after her second Pfizer shot. Her symptoms are similar to those of people suffering from PASC. She's having a really hard time getting sympathetic care here in our small town, Corvallis, Oregon. Are there any resources you could direct her to? I've done a lot of searches to try and find something, anything, without luck.
Yeah, so this is a challenge. One of the nice studies that's based in Yale that we've collaborated with is the LISTEN study, LISTEN. Akiko is involved in that. There's also a connection with David Petrino down at Mount Sinai. And this is a study where they're looking at people with long COVID, but also people that develop similar issues post-vaccination. And trying to understand, because sometimes there seems like a symptom overlap. A lot of times, some of the therapies that we use for long COVID help people that have injuries, post-vaccination. So feel free to look at the long COVID paper, and a lot of times you need to go to more of a major center, and then maybe continue to follow up afterwards with telehealth visits. Yeah, this is really tough, and because we acknowledge, right, and I think Paul Offit always has talked about this. Vaccines are biologically effective agents. It might be 1 in 100,000, it might be 1 in a million, but when you vaccinate 300 million people, when you vaccinate billions of people worldwide, that 1 in a million, that 1 in 100,000, that starts to add up to a number of people that we really need to help take care of. A nice thing, and this goes back decades, is realizing this. A fund was set up. 75% of every vaccine that's given out goes into this fund, so that when people end up being adversely affected, there's a fund to help take care of these folks. So make sure that this is reported. Make sure you work with your doctor. And if this is adjudicated, if they establish this connection, which has happened for a number of patients I take care of, they can actually get support.
Susan writes, I had a preemptive kidney transplant 5 years ago. I am up to date with vaccines and boosters, 11, plus 2 Evusheld injections, 3 PEMGARDA infusions. I had COVID 2 years ago and received belatacept when it was authorized. When I ask my transplant center about treatments, they always say, well, the disease isn't so serious these days. No remdesivir if you're not in the hospital, and you could try molnupiravir if you don't want Paxlovid. My feeling is the disease hasn't changed, but we are coping with it better because of vaccines and acquired immunity from infections. Is my transplant center right?
It's troubling. You're right. As we've repeatedly talked about, the virus did not magically become something innocuous. It's this wall of immunity, and folks that have had transplants and because of some of the medicines don't have as great a wall of immunity. Those are the people that we're seeing in the hospital. Those are the people that are not surviving the infection. The most effective time to intervene is either before or during that first week. You want to find out, can I take Paxlovid? Is there any kind of a drug-drug interaction? I think we covered last week that of the 15 million courses of Paxlovid given in the U.S., only about 500 individuals had drug-drug interactions or suspected drug-drug interactions. Tacrolimus, which you might be on, is one of those. So that might interfere with your ability to take Paxlovid, which would be recommended as first line. If you can't navigate the drug-drug interaction, then you do want to look at remdesivir or molnupiravir. But you are right.
Walter writes, I have a question regarding Broncovaxom OM85 and its use for preventing recurring respiratory tract infections. My primary healthcare provider, who notably does not recommend COVID-19 vaccines even for elderly patients anymore. Yeah, I know I may need to reconsider my choice of doctor. Recently suggested Broncovaxom to help with my recurrent RTIs, which I suspect are viral in nature. For context, I'm 40 years old, healthy male. Does this recommendation make sense given the evidence for Broncovaxom's effectiveness, particularly in such cases? I'd greatly value your opinion.
Yeah, so Bronchovaxum is an interesting product, right? So it's sort of like a desiccated bacterial outer coat product that it's actually, I think it's actually licensed in Europe. Here, you buy it from Amazon.com or something. And we don't really know, but the idea is this gets some sort of priming of the immune system. So you always got a little bit of inflammation going on, and then when you get some kind of infection, you're more ready to go. And really the outcomes that I remember for the Bronchovaxum was like people end up getting less antibiotics. I don't know if they end up getting less antibiotics because they're on this and people think like, oh, I don't have to worry about antibiotics. But yeah, the data is not like, the most compelling under the sun. It doesn't appear that there were safety issues with doing this. And yeah, most important, if your doc's not pro-vaccine, you may want to look into that.
And finally, Zaharula writes, these comments are my own, do not represent my organization or hospital. I want to clarify something that was said in TWiV 1168. Parents have always had the consent for any type of medical treatment for their child, including getting vaccinations. I can't even give their child Tylenol without their consent. They also receive vaccine information statements from the CDC for each type of vaccine that their child is receiving at the time before the vaccinations are given. Federal law, this is a quote, requires that healthcare staff provide VISs to a patient, parent, or legal representative before vaccinations are given. This is required in both public and private sector healthcare settings. We as medical professionals do not make the decision to vaccinate children. Their parents do. It's always been the parents' decision to proceed with vaccination or not. However, paraphrasing Dr. Offit, there are no risk-free decisions. Choosing not to vaccinate your child is still a decision and one that carries extremely great risk. Nothing in life is risk-free, and choosing not to do something is still a choice, and all choices have consequences. I try to explain to parents that choosing not to vaccinate their child carries the greater risk of getting the vaccine-preventable disease, a risk that includes death. Unfortunately, during my 32 years as a pediatrician, I've taken care of pediatric patients with polio who lived in iron lungs, kids who have died of varicella, pneumonia, pulmonary complications, kids who died of epiglottitis, respiratory failure, sepsis from Haemophilus influenza type B, kids who died from pneumococcal sepsis, babies who died from pertussis, kids who were not vaccinated with COVID vaccine and had MIS-C and needed critical care, kids in respiratory failure from flu infection, and countless other children with lifelong disabilities after having vaccine-preventable diseases. So parents have always had the right to choose to vaccinate their children. They have always had the information about the vaccine given to them before proceeding with the vaccinations, and they have always had the opportunity to discuss the vaccinations with their pediatric provider. In addition, there are the post-vaccination safety monitoring systems, including the Vaccine Adverse Event Reporting System, vSafe, the Vaccine Safety Data Link, and the Clinical Immunization Safety Assessment Project. I am confused as to what RFK Jr. thinks we have been doing all this time. I would also ask, in his career as a lawyer, how many patients has he treated? Has he actually sat at the bedside of an infant struggling to breathe with pertussis? Has he had to talk with a grieving parent after their child died from pneumococcal meningitis? And I wonder, would he be willing to do that now? Thank you again for all of your efforts in educating all of us and for all the great science communication. I'm proud to be a Microbe TV supporter, and in the spirit of Thanksgiving, I'm most thankful for all that you and the other hosts of Microbe TV do.
Yeah, no, I mean, that's fantastic. Thank you for sending that email. I mean, not really much I can add. I mean, I think you're basically putting it all out there. Everything you're saying is true.
That's TWiV Weekly Clinical Update with Dr. Daniel Griffin. Thank you, Daniel.
Oh, thank you. And everyone, be safe and enjoy the holidays.